Hello, my name's Gareth Morgan. I'm a consultant haematologist and professor at the Royal Marsden Cancer Institute in London, and we're here in an e-cancer interview, and I'm with Philip McCarthy, who's a senior consultant at the Roswell Park Cancer Institute in New York State in the US. And we both just come from one of the plenary sessions at the IMW discussing the role of maintenance treatment after autologous stem cell transplant for younger patients and continuous treatment in older patients. So Phil, tell me, what did you think of the meeting today?
Oh, it's always exciting. There's lots of new agents that were discussed today. And in particular, we discussed our study, which is the role of lenalidomide maintenance therapy after single autologous transplant for multiple myeloma patients less than 70 years of age. And we found some interesting results. We found that there's a great deal of there's a great difference in time to progression in patients who receive lenalidomide versus maintenance therapy. And when we unblinded the study back in 2009, in December, we found a trend towards an overall survival benefit. And now with the latest analysis in April of 2011, we've seen a significant difference in deaths, in that the patients who receive placebo have a higher incidence of death rate, or a higher death rate, than compared to the patients who receive lenalidomide.
I'm very interested in that. I mean, it's a fascinating survival benefit, and I think it's really a terrific result. So in the context of the two other studies, the IFM study, which is designed very similar to yours, and Antonio Palumbo's study looking at MPR followed by R maintenance, where do you think that results puts us now in the use of Revlimid maintenance?
Well, it's interesting. In the IFM 0502, it is a similar study in terms of maintenance therapy after autologous transplant, but there are some differences. The IFM study had a very different patient population in terms of induction regimens. Most of their patients either received VAD or bortezomib and dexamethasone. Our patients, 74%, either received lenalidomide or thalidomide as part of induction therapy. So it's a different upfront population. They had a 2-month consolidation therapy soon after their autologous transplant. We did not have that. About half their patients received DCEP, the combination chemotherapy arm, or alkylating treatment as part of their further induction therapy. So there are some differences. Now, they are seeing a great benefit in terms of time to progression, progression-free survival. They've not seen an overall survival benefit as of yet, and that may be due to the different patient populations.
I have a kind of real question for you about that, which gets glossed over a little, and that question relates to their study did differ from yours in one significant way, in that their control arm had consolidation treatment with Revlimid. So how do you think that difference could impact on the results?
It could, in that could have, it was a full 25 milligrams a day for 2 months, and it could have changed things in that the patients now have had a exposure to lenalidomide, and that may push things out in terms of survival, perhaps, although it didn't really affect too much their time to progression. But it is a different approach than what we did, which was to start at a lower dose after recovery from the autologous stem cell transplant.
The other difference that I kind of learned today, or the last few days anyway, is that I thought the median follow-up on yours was, your study was slightly different to the French study, which it is, but you actually started your study sometime before, so you have patients who've been on treatment for longer?
Yes, we opened the study in 2005, and the accrual was slow. And then it picked up from 2007 on. But serendipitously, that actually may have proven very interesting for the study results, in that the death rate has been primarily seen in the patients who entered study in 2005 and 2006. So the actual keeping the study open for a longer period of time has actually allowed us to see this benefit, especially since we allowed crossover, since the primary endpoint was time to progression benefit, and that showed a benefit early on in 2009. Patients were allowed, who had been on placebo, were allowed to cross over to lenalidomide. And so we were concerned that we may not see a survival benefit, but now we are. We think it's because of those early patients who did not have a chance to cross over to lenalidomide.
So based on those two facts, the shorter and median follow-up and this difference in protocol, do you think there's the potential that in the next few years we'll start to see a survival benefit in later cuts of the data from the French group?
I think we may. They have, at least at the presentation today, Dr. Atoll had actually more deaths in the lenalidomide arm when he presented this in ASH, and now the deaths have increased in the placebo arm. They're almost essentially the same. And so we may see a benefit over time because of that prolonged lenalidomide exposure. Now, their study's different in that they stopped lenalidomide treatment in the study arm. And so we won't know what will happen over time, but that potentially could translate to an overall survival benefit within the next year.
So I've asked you this really rather difficult question before, and that is, your study was mandated on TTP as a primary endpoint. You hit the primary endpoint of TTP, and now you've hit an overall survival benefit endpoint. What does that tell us now about what is the role of lenalidomide maintenance after stem cell transplant?
Well, in particular, we saw a benefit in patients who had received lenalidomide as part of their induction therapy, although we did see a benefit in TTP in all stratifications, prior thalidomide exposure, high and low beta-2 microglobulin. I think this translates into a strong consideration for lenalidomide maintenance therapy for maintaining response and diminishing the chances of both disease progression and, in particular, increasing the chances of overall survival.
So I've been very excited about these maintenance schedules, and I think it's the first time we've seen such huge benefits in PFS with both studies in the transplant setting hitting their endpoints and Antonio's study in the elderly group. And so, but we've also heard these other stories, the stories of second primary malignancies, and I'd like you to address that question in the context of the risk benefit for any patient you see in the clinic.
Sure. We think there may be a signal, and it's hard to tell because the number of events are small, of, in particular, hematologic malignancies, a small number in the study arm. In particular, AML, and that's different from the French study where they saw more ALL and Hodgkin lymphoma. But when we did an event-free survival analysis, there's still an overwhelming benefit for the use of lenalidomide, and this translates into an overall benefit. And so while we think that the signal may be there, and we need to study it more, and we need to figure out which patients are at risk for developing these cancers, we think that the risk of progression is so high that we would recommend lenalidomide maintenance therapy for patients because of the time to progression benefit and the survival benefit.
So on trial patients, it's very clear there's a tranche of studies out there, and I think the clear intellectual role in this is you should complete all of those studies. There's another question though. What is maintenance treatment? Is it 2 weeks? Is it 2 years? Or is it till disease progression? And what data do you think we have that can inform that question?
Well, we think in the CALGB study, we definitely see prolonged maintenance therapy as being beneficial. And the study was designed so that patients would stay on maintenance therapy until progression. So we've seen a benefit in patients who've now been on study drug for at least 5 years. And some of those patients maintain their quality of life, they have not had progressive disease, they have reasonable blood counts on a relatively low dose of lenalidomide. So I think that this is quite exciting in that this drug appears to be very well tolerated. Some patients from the original phase 1/2 studies have been on for almost 10 years and without evidence of major problems, without progression. And I think this is quite exciting. Now, trying to identify which patients are going to benefit the most is going to be the next step that we have to undertake.
So I guess you are hinting at, and I guess it's my experience, that long-term Revlimid is very well tolerated and doesn't impact on the patient's quality of life. what do you think the mechanism of action is long term? How do you think it's working?
That's a good question. And it's interesting in that, at least when we did a subgroup analysis, that patients who received lenalidomide and responded to it, and the vast majority of patients do respond to lenalidomide, maintain that response. So perhaps it's the depth of response. And as you know, lenalidomide has a variety of different mechanisms of action. So it's not clear if it's the immunomodulatory one or the direct anti-myeloma effect. But we do know, because it's maintaining this without major side effects, that it's probably, I'm guessing that it may be immunomodulatory, which I find quite interesting, or perhaps interfering with the myeloma stromal cell interaction.
Yeah, I kind of like the two latter explanations. I think it's fascinating that it could be altering the biology of residual disease in the patient over time in a beneficial fashion. And that sort of fits with, you know, the consistent feature of some of the studies that has been, when you stop the lenalidomide, the patients start to relapse again. And I think that sort of argues that you should continue patients on it long term.
Yeah, we struggle with that. When we had patients on long-term thalidomide, a lot of them had a lot of side effects, in particular the neuropathy. And a lot of them, knowing the risk of progressive disease, chose to stop because they just couldn't tolerate it. Whereas this is so well tolerated, and so far we've seen minimal side effects. Now, there are some patients who just don't tolerate. They get a rash, or
absolutely.
You know, it's a fraction of the patients, but it's still there. But for the majority of patients who are able to take this drug with minimal side effects, I think it's a worthwhile consideration for long-term therapy.
So the CALGB, an important American institution and trial organization, we've done a great job with this study. How are we going to make lenalidomide maintenance better?
Well, that's a good question. The BMT-CTN has a trial now that we are participating with, which is looking at single versus tandem versus single followed by consolidation therapy, all followed by maintenance therapy for 3 years. And we think that's going to be an important question for the role of consolidation after transplant. Now, I do think that since some patients may not respond to lenalidomide in the same way, we may want to think about combination drugs, other oral agents with different mechanisms of action. The proteasome inhibitors are an attractive class of drugs that may have utility, especially if they can be taken together with minimal side effects. I think that's the most important thing to consider, is that patients want to get back to their usual lives. They want to not have to see the physician that often.
Absolutely.
And get their counts checked occasionally, or check in to see what's new, but they don't want to be seen every week by the physician. And so I think that a well-tolerated drug that is easily monitored safely over a prolonged period of time, is with potentially different mechanisms of action, is going to be sort of the future for this field.
I agree with you. I think it's fascinating to speculate on what drugs synergize with lenalidomide and have those characteristics of tolerability, which is what you're talking about. And I think the HDAC drugs in combination with lenalidomide have it's a very interesting synergistic combination. But even antibody treatment, so the CS1 antibody in combination with lenalidomide may be very appropriate for this sort of setting. So what do you think of that sort of idea?
Yeah, I think those are reasonable. The problem with antibodies is they have to be delivered frequently, and that's an issue until drugs can be administered that have prolonged effects. Now, rituximab is sort of the paradigm.
It's the paradigm. Once every 3 months.
And that's pretty amazing. And if we can develop an antibody that can be administered relatively infrequently, I think that would be a great step forward. I think the HDAC inhibitors have been, as you say, quite beneficial when combined with other agents. And I think that's another well-tolerated group or class of agents that potentially could synergize and provide long-term disease control.
So I've really enjoyed the meeting and this discussion with you. But if I ask you one sort of final important question, we see now in myeloma induction, transplantation, consolidation, maintenance. How are we going to go forward with these combinations of different settings and make things better for the patient?
I think we have to risk stratify the patients. We have to figure out who, your work showing that there's multiple cytogenetic abnormalities, multiple molecular abnormalities that allow us to be able to identify who's at very high risk and who do we have to target in a very aggressive approach. Whereas we may have some other patients who have less aggressive disease who can be maintained without a multi-drug approach. That may be the next leap forward, where we can figure out which patients are going to require which types of therapy. And with the second cancer issue, can we figure out which patients are going to be at risk for this early on, and then design our therapies to either avoid certain agents, use other agents that may be less problematic. The problem is that the numbers are so small that it's going to make it hard, and that's going to require a lot of thinking and a lot of patients on trials to be able to figure something out like that.
It's really interesting, but I guess 20, 30 years ago in Hodgkin's disease, that might have seemed like a terrible disease, but once you found out how to make some impacts into the survival, at some stage you have to think about treatment or dose reducing your treatment. I don't think we're there in myeloma yet, but do you think that's potential for the future?
Absolutely, and that's a wonderful example in that we've gone from MOP chemotherapy for Hodgkin lymphoma to ABVD, and now to attenuated ABVD involved field from mantle radiation. So we've made huge advances in Hodgkin lymphoma, and I expect to see that that is the next step with the number of great agents that we have and the new agents being developed to really generate better responses. While we're seeing great responses up front, I think the goal is complete response, or at least a good enough response that allows for maintaining the patient's status for an extended period of time without disease progression or without symptoms from their disease.
I have to say I totally agree with your concept around moving towards a personalised medicine strategy for myeloma patients. I think to achieve those aims, we're going to have to be able to identify low-risk, stable disease that can be treated in one way, and this ultra-high-risk group of patients that we really need to go in all guns firing to achieve. Do you agree with that?
Oh, absolutely. And as was presented here at the meeting, there are some patients who may be candidates for such aggressive approaches as allogeneic transplant. But I think that we really need to get a better understanding of these high-risk patients up front, and get the community, the treating community, to agree on this, and then develop pathways for treatment for these very high-risk patients.
Phil, on that note, which I think is very optimistic for the future, thanks for coming to this interview, and it's been a pleasure talking to you as always.
Thank you very much.